Good morning, everyone. I'm Diane Geronimus. I'm a licensed clinical social worker in Medicare home health, but I also have the privilege of being a caregiver support group leader for Broward County Elderly and Veteran Services. I have a long history of working with seniors, disabled adults, and their caregivers, and looking at so many of the challenges that they've faced. A variety of cognitive, of behavioral, of physical limitations. The interesting thing is that the challenge has always been, and way back when I started, they were admitting people with, pre-senile dementia. The world has become a different place, but some of it is still the same. The problems that we face seem pretty much insurmountable a lot of days, and that's normal because we've got no roadmaps. We don't have a how-to book for what to do. And perhaps the most difficult part is we never really know which person we're going to wake up with and have to deal with on a given day, because there are so many different variations. I see this conference as kind of a beginning to start to look at some of the challenges. And Charlotte knows, and many of you know, looking at the research of this, I think, is important. The clinical research, how you do things. I'd like to share, just give a framework. I'd like to share a quote that I really like from Rosalind Carter, which she stated in May of 2011 at a special Senate Committee on Aging. She said that there are four kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. With that in mind, we've got a whole lot of work to do in understanding what each of these challenges are, and that's going to help us along the way, whichever of these paths we end up with. I am very privileged to have an excellent panel who have differing aspects and are going to discuss different aspects of dealing with the challenges of caregiving. Michael Norfleet is the Senior Program Manager for Southeast Florida Alzheimer's Association. He's going to talk about the 3 stages of Alzheimer's disease and some communication techniques. Dr. Nashira Pandya is a professor and chair of the Department of Geriatric Medicine at Nova Southeastern, and a whole bunch of other things she does too, which I think are in your program. And she's going to discuss what really matters in the 4 M's of age-friendly healthcare, looking at goals, looking at nutrition, some of the things that kind of come up every day. And then the future is Dr. Laird, Dr. Rosemary Laird, who is the founder and chief medical officer of NAN, of Navigating Aging Needs. That, I hope, goes to the future of where we're going. She's going to discuss that and caregiver resources. Thank you all very much.
I'm the Senior Program Manager for the Southeast Florida chapter of Alzheimer's Association, and I'm based out of Broward County. I'm very animated, so I will let you know that I'm very animated. The reason I do is I was a caregiver as well, not personally like some of you all. I was a caregiver for other people's family members. I started out working in memory cares and they call the secure units and things like that. And I worked in adult daycare. So my passion is caregiving. So the reason I want to do this program, the reason I want to do this program about communication is when I've talked to people before out in the public, the main thing that I get questions about is how to communicate with their loved ones. When I did memory care, the main thing is people would always say to me, I can't relate to my family, or I can't relate to my mom, I can't relate to my dad, I don't know how to communicate with them. Well, there's a couple stages. The first stage we're going to go through is the early stage of the disease. In the early stages, people can communicate pretty much unnoticeably. Like if you're having a conversation with your mom and dad, they can communicate back with you like they normally would. They may have an issue sometimes with thinking of a word or something like that, but they can communicate normally, and you may not notice. I call it a clarity moment. Most people in the early stage, they say, maybe there's nothing wrong with my mom, maybe there's nothing wrong with my dad, but you can notice, but you're kind of denying it a little bit. So in that stage, you just have to make sure that you're careful. Where? Oh, they're not going to give it to me, so I'm going to be on this doing it all together. I'm going to cut it a little short, though, too, because I want to give you guys something that you can use right now. That's another thing about how I talk to people. As a caregiver, doctors tell you all the time, oh, you have a diagnosis of the disease. And as a caregiver, you're saying, well, what do I do now? This is what I want to do. I want to give you something that you can use, techniques. One thing about my techniques that stick in your head, if you don't remember anything else I said today, stick in your head, deflect and redirect. Now say it with me. Anybody can tell me what that means? Change the subject? Okay. Similar. Okay. Changing the subject, yes, that's what it means. Deflect the behavior or what's happening during that communication, because guess what? That person is communicating something to you. You have to just understand what it is, but in the meantime, deflect it. Okay. So the other one is go into their moment. Got that one? Repeat it.
Go into their moment.
Anybody know what that one means?
Just be with them where they are at, rather than you trying to bring them to where you're at.
Look at you. Here, take the mic. You can give the training. So, yeah, those are two key things you will need in communicating. Because, see, people think communication is just sitting down having a conversation, whatever. There's a lot of things in communication. They are communicating something to you. If mom's riding a red bike, and the reason I say this, techniques, okay? Mom's got a doctor's appointment, right? You got to communicate, and you got to get mom to move, or dad, or auntie, whoever, right? You got to get them to move. I have to switch because they be my PowerPoint, so I'm not going to give you that. I'm going to just give you techniques. So you got to get them to move. So part of my technique is you have to direct what's going on. You have to communicate to them what you want to do, even if you're communicating that early. So if mom's got to go to the doctor, you might have to plant that seed and communicate to her that she has something to do. Look at you. You're shaking your head. You've been there. So you have to communicate to them early what you want them to do. You have to remove barriers because they get easily distracted. And this is usually in the middle and later stages, okay? So remember, deflect, redirect, go in their moment. Got it? Two of those. Okay, so another thing about communicating. In the different stages, middle stage, late stage, it's very hard to communicate sometimes. So part of communication is building that bond. I get family members all the time, and I keep referring family members all the time. They can't relate to the family member because guess what? You didn't build that bond in that middle stage. You didn't communicate with them. Early stage, you're setting the foundation. Middle stage, you're setting the next foundation for what's going to happen in the later stage, okay? Middle stage, that hug, that hand holding. You're basically building on what's going to happen in the later stage. You have to do that as caregivers. I meet sons and daughters, they've never really had the relationship where they hugged and they cared. When you have the disease, sometimes the family member is going to revert to something that they weren't before. So you have to understand what the communication is they're giving you. If they like hugs, give them hugs. Because in that middle and late stage, that may be the only way that you can communicate, okay? Back to the early stage. Ask the person how they like to be communicated. If they like writing things down, write things down. You may have to talk early, middle stage. Start getting them communicating. Mom, it's time to eat. Dad, come on over. Let's go over here and have a seat and watch some TV. You might have to direct them. You're still communicating, but you have to use hand signs and gestures, okay? So, those are some basic tools that I wanted to give you guys because I thought I had a PowerPoint, but And you know, and a point, you guys are almost gonna have me up here singing. I've always wanted to do this. This is a big place. The last thing I'm gonna give you, you can write this down. And the reason, it's not a big thing that I don't have the presentation, because you can always reach me. I have an 800 number. It's 1-800-272-3900, okay? The reason I'm gonna give you that number, if you have any issues, questions about being a caregiver and dealing with this disease, on there, as we say, boots on the ground, I'm boots on the ground. They're brown, but I'm boots on the ground. Okay, I'm gonna give it again. Everybody got your pen and paper? 1-800-272-3900. Okay? I'm gonna give you my website. No, it's not my website, it's Alzheimer's Association website. But guess what? If you want to contact me, you can get to me through that. I love doing these presentations. I will come out, do them with family members. I will do them with groups, hospitals, wherever. Just let me know. I'll come. So the website is alz.org. I'm going to say it again, alz.org. Reason being, the presentation that I was going to do for you today, it wasn't that funny. So the presentation I was going to do for you today is on that website. We have so many programs that are available to you all 24 hours a day, okay? You can go on there, you can do those. As caregivers, please go look at those programs. I love it when caregivers say, oh, I don't want to do a program, I don't want to do a program. So how do you learn how to care for someone with this disease if you don't know a lot about it? Go to that website and check out some of the programs. One of them being, it's called All Stars. It's a great program. You take that program, it gives you at least the basics of dealing with this disease. Communication, behaviors, financial stuff. It's a lot of stuff with dealing, just the basic. So go there and check that out. Another thing about the 800 number that I gave you, master's level clinicians on that line. Master's level clinicians that will sit on that line. If you have an issue, they will sit there and talk to you. Prime example, they sat on there 8 hours one day with someone that was having an issue with the family member that was having a behavior. You can't get no better than that. You pay more for therapy, don't you? So go there and check it out and see what resources are there, okay? So I'm gonna get off this microphone because I'm kind of enjoying it a little bit. So I'm gonna go ahead and pass it on to my colleagues here because they're kind of gonna get the hook for me. But we all appreciate you coming out, and I appreciate you listening to me get banner on, and you can clap now. Thank you. Appreciate you. Love the caregivers. Give the caregivers a hand. All the caregivers, you guys deserve a hand, I'm gonna tell you. Okay? Thank you. Want this?
Thanks so much, Michael. I don't think I can perform like that. So this is me again. I'm Dr. Naushira Pandya. I want to talk to you about what really matters. And you all have a sense of what really matters, but I want to formulate it in a simple way that you would remember. So we're going to use the 4M approach, okay? 4 M's. That's something, if you remember, you will cover all the basics of prioritizing what's important. So what I want to talk to you about is what really matters. Not just what matters, what really matters. And it can be different things for different individuals. And what I'm going to talk about, again, unfortunately, no financial disclosures. I'll give you a framework in which to look at the care of the older person, the person you're taking care of with dementia or Alzheimer's disease, to be specific. What are our goals? We want to preserve function and maintain independence for as long as possible. We want to reduce the burden on caregivers and enhance the quality of life, provide a safe environment, and be socially engaged. Remember, I told you isolation and loneliness is actually a risk factor for dementia. And then for specific treatments, what do we want to do? Especially as Michael was alluding to, in the later stages, in the moderate and severe stages of Alzheimer's disease, when cognition gets worse, you might get mood disorders, depression, apathy, agitations. A lot of you are familiar with sundowning, right? We want to reduce the effect of that, to enhance mood if there is depression and apathy, and treat the psychiatric and behavioral symptoms. So those are overall goals. And what the 4M approach comes from is the Institute of Healthcare Improvement and the John A. Hartford Foundation. And it's supported by several large healthcare organizations, including the American Hospital Association and the Catholic Health Association. But a lot of institutions, including Nova Southeastern University, are now promoting the age-friendly approach, the 4M approach to age-friendly healthcare. And so we're trying to impart this training to our providers and to our trainees, our students and residents, to look at elder care in this way. So what are the 4Ms? What matters? And that could be what matters to that person. It could be goals of care, preferences for living, for food, and including advanced care planning, which I prefer to refer to as advanced illness planning. What do you want to do when you get really sick? Who would you like to make your decisions for you? Do you want to be in an intensive care unit? So that's part of what matters. And then medications, that's the second M that's important. Are your medications appropriate? Are they allowing you to do what matters? So again, it all comes back to what matters. Can you do what matters to you? So that's the second M. And medications can interfere with mobility. They can interfere with mentation. So they interfere with the other M's. Okay, so you don't want medications that make you too drowsy or impair your balance, put you at risk for falls. And then the third M is mentation. So the big things in mentation with dementia patients are obviously the presence of dementia and cognitive impairment, but there are two other Ds, delirium and depression. Okay, and delirium, unfortunately for older adults who are sick, is not a nice, happy state. Okay, anybody seen patients with delirium where they suddenly change, behave differently, might hallucinate when they're sick? Anybody familiar with delirium? Yes, and unfortunately the word sounds like it's a happy state, but it's not. And usually there's an underlying medical problem. And then mobility, so to prevent falls or to promote mobility as safely as possible. And so that again goes back to what matters. So this is the basic framework of the 4Ms. And this is my take on what really matters. These are the things that I feel really matter. So that's the first M. All right, food really matters. The type of food, quantity, enjoyment. And I've told all my friends, if I'm not able to speak for myself, I still like Indian food, all right? And I think some others of you do, okay? So make sure I get some, okay? The other one I mentioned is serious illness planning, or it could be a living will. It could be a healthcare surrogate. What do I want when I get really sick? How do I want to be treated? All right, and that's a discussion to have as early on as possible. Spirituality, what matters to you? Try to and understand that person in the sense of who they are, what mattered to them, what do they believe in, what do they practice. Activity, and that's been talked about. Sleep matters because a lack of sleep can worsen cognition. And unfortunately, lack of sleep goes with the territory of age and dementia. The people around you matter. You know, who is with you, who takes care of you, who keeps you company. So I often tell my younger patients, they come in with the grandparents, you know, spend some time with them. You know, I'm busy. Okay, do your work, bring your computer, do your homework with your grandparents. You know, spend time with them. And then financial security really matters. So that's something you need to start planning as early as possible when there's an indication that the person has memory problems. The second M is medications. Always have a current list of medications that either you're taking or the person you're taking care of. Have their current list and take it to every specialist, every clinic. Keep that list current. And preferably take the meds with you, okay? Carry a bag because sometimes there's confusion. So with medications, you are entitled when you go to doctor's appointments to question them, is this necessary? Is this helping me? I've been on digoxin for 15 years. Do I need it? And often the answer is no. Does it interfere with what matters to you and your mentation? Is it making you drowsy? Is it making you unsteady? The other thing is cost and complexity of medications. So your caregivers, your providers have to work with you as far as costs and how complicated this is. I also practice endocrinology, and I'm really trying, and this is how we're managing diabetes in 2022, is to simplify diabetes, okay? The number of shots, the number of pills, the number of finger sticks, we're trying to simplify all of that. Okay, so cost and complexity. And does this medication improve my quality of life, or is it worsening my quality of life? So you're entitled to ask those questions. So that's the second M. The third M is what I refer to as the 3Ds. Dementia, which we know this person is suffering from, depression, which can occur in the patient with dementia, and delirium. So let me see if I have this information. Yeah. So delirium is very rapid change. So I had a colleague who said, "Oh, my dad started, peeing in the bedroom, and I think his Alzheimer's is getting worse." I said, "No, the Alzheimer's is not getting worse. Doesn't happen in 2 days, right?" So something is going on, a bladder infection, a medication side effect. You need to do a medical evaluation. So delirium is very rapid. It can wax and wane. It can be hallucinations, usually visual hallucinations. And there's often an underlying cause. It could be medication, acute illness, dehydration, side effects. And so it needs an immediate medical evaluation. And depression can occur in people with dementia. It might be just apathy. They're not interested. They're sad. They're not eating. They're losing weight. They're not doing the things they're doing. I was medical director for a nursing home in Michigan, and my office was next to one of the patient rooms. Sadie, I always remember her. So she always played her radio loud, and it was a lively room, visitors and things, and I would often stop by and see her. And then for a week or so, she just stopped saying anything, no radio, nothing. She was just sad, looking out of the window. A totally different person. And so I did a thorough evaluation and couldn't find anything physical, so I ordered some lab tests, and it turned out her calcium was sky high, very, very high. So she had a parathyroid problem, but it just manifested as no radio, no talk, and just, sadly staring out of the window. Thank you. And then obviously the third D is dementia, which we've already talked about. The third M is mobility. So what can interfere with mobility? What can increase your risk of falling? Again, medications rears its head, okay? Always look at the medications, including what they might be taking over the counter. How many of you know that Tylenol PM is bad for you? Few very wise people over there. The rest of you, Tylenol PM is bad for you, okay? Because Tylenol's okay as long as your liver is okay, right? But the PM is Benadryl. So for older adults, that Benadryl can cause confusion and worsen cognition, okay? So look at what people are taking over the counter. Look at the medicines at home. And if you're visiting a person with dementia, check all the medications, all right? So sedatives, psychoactive medications. Look at the hazards around the house. What's increasing the risk of falls? Okay, one of my colleagues says, look at the grabbers and gropers. You're holding onto furniture and moving from the sofa to this to that. Those people are at risk of falling. And then look at the home modification. What do you need in terms of rails? Remove clutter, uh, a raised toilet seat, for instance, the right bed height, okay? And what assistive devices do you need? So use the right things. A lot of my patients, have mobility problems, and I look around the room, I say, where's your cane? Where's your walker? Oh, I left it in the car. So I said, what, you don't want to look like an old lady? So, I have arthritis, I have to use a cane, so use what is necessary, and obviously you want the correct device, and there's plenty of expertise. Just want to touch on behavioral and psychotic symptoms of dementia, or psychological symptoms, some people say, BPSD. So you know that suddenly there could be agitation, confusion, worse at night. That's very frustrating to caregivers. Sometimes behavior can be so detrimental that leads to nursing home placement. So how do we manage this? And when the behavior really deteriorates, you can be prone to falls, infection, develop worsening incontinence. So while you might get given medications to reduce anxiety or an antipsychotic, you really have to look at the underlying problems that are leading to this behavioral change, okay? So medications can be given, but I want to finish with this. How do you interact with the patient? And Michael talked about this, interacting with the patient, be with them, be in their world. So travel with them. Don't disagree and don't keep correcting them. Yes, they might say something wildly incorrect. Don't keep correcting them, okay? Just go with it. All right, and the other thing is eye contact, calm manner, eye contact, allow space, sit at the same level, don't brush, don't be threatening. Don't scold, validate what they're saying. And I have heard so much wisdom from people with dementia that I consider myself incredibly privileged as to what I've heard and the discussions I've had with my patients. I spoke about medical evaluation. So when there's a change, agitation, behavioral symptom change, look at the medical cause. Is it medications? Is there depression? Is there underlying mental illness like bipolar disease? That can be a problem. So look at all those triggers and then focus on quality of life. In all of this, come back to what matters. So routine activity, food, home safety, a routine that's predictable, that's important. Optimize nutrition. And really don't restrict them. You want to eat cake and ice cream? Eat cake and ice cream. Isn't that great? Yeah. So cake and ice cream. And some of my Caribbean patients said, but he likes rice pudding. Rice pudding it is. So food, whatever you want. Even if you have diabetes, I would say if you have dementia, eat whatever you want. Let the providers help you with your blood sugar. And anyway, as you get older, with dementia, the glucose goals are more relaxed. You don't have to be as tightly controlled. So those are the important approaches. Yes, there are medications, the pharmacological approaches. What I just talked about was non-pharmacological. But there are medications for depression, for agitation. Some are off-label. So drugs like Seroquel, risperidone, so they are antipsychotics. They are off-label. They can be used in small doses if agitation or aggressive behavior is particularly problematic, but they're not forever. Okay, I've already talked about on the low-hanging fruit in this time. When you're healthy, is to manage your blood pressure, your blood glucose, and your weight. That will help towards reducing the incidence of dementia. And then I just want to talk about the choosing wisely. This is a national movement by the American Board of Internal Medicine. So this is things that physicians and patients should discuss before we just routinely do whatever we normally did. Okay, so we routinely do what we normally do. So don't do genetic testing as a predictive test, okay? It may lead you astray. It's not appropriate for everybody. And don't use cholinesterase inhibitors like Aricept and Razidine if you have advanced dementia. And they also have some gastrointestinal side effects. Not that these drugs are necessarily bad. Don't use them in advanced disease. Look out for side effects, okay? And I talked about antipsychotics. And the other thing, which is quite serious, is when you get swallowing problems and nutritional problems and weight loss, a lot of people used to resort to feeding tubes, putting feeding tubes in patients with dementia. They do not prolong life. They don't prolong the quality or the quantity of life, okay? So I think the tide is turning. We're having more discussions about what to do with nutrition and late life with dementia. Use finger food, cake and ice cream, whatever it is, but don't resort to high-tech modes of nutrition that will actually lead to more discomfort and impair quality of life. So I think I'll stop here, and thank you so much for your attention.
Well, very good. Good morning, everyone. Thank you. And I am very happy to follow my wonderful colleagues here who really set the stage for what I'm going to talk about. So I'm Rosemary Laird. I'm a geriatrician. And I'm here to talk about a really unique program. It is the only program in the world of its kind, and the only place in the world right now where this is offered. Guess where it is? It's right here. It's Broward County, Florida. And you're going to find out there's some specific, yeah, it does. It deserves applause. It really, really does. It really, really does. So let's see. Now, I'm going to be in a lot of trouble if they don't find my slides. I am not the entertainer that Michael is, but I have I have no doubt. But the reason I say I think they set the stage well is because you've heard the complexity of what you all are facing, right? And, you know, this isn't a simple, straightforward illness that has one solution that fits everyone. And so what we're going to talk about is what we've put together is a way of providing individualized support. There is a lot of information that is generally useful to all of us about this illness, but there is an acute need for individualized support that spans the medical, the emotional, the social, the financial, legal, everything about our lives. Okay. Everything about our lives becomes a challenge when we have this type of illness. And what we've done as a state, really, is the Department of Elder Affairs, and they're going to get the next round of applause, about a year or maybe a year and a half ago at this point, asked a question. How could we do something different to bring caregivers, family caregivers of people with Alzheimer's disease, the kind of support I think we would all want people to have, but doesn't seem to be available out there? Covering those two real basic areas I talked about, covering the complexity, but individually targeted at what a specific caregiver and their loved one with Alzheimer's disease needs. So they looked around and said, well, where is that? Is there another state that is doing it? Is there another company that is doing it? And having found nothing, they were smart and said, well, we've got smart people in our state. Let's find out if there are some solutions we can come up with. Well, without bragging too much, I will say that I'm a very fortunate individual who found some associates of mine who have many years of experience, and together we put together a company called Navigating Aging Needs. Oh my goodness, thank you. Well, we can just stop right there. I think I'm done. We'll have her come up and tell you all about it. Navigating Aging Needs is really the culmination of my 30 years. I'm going to my reunion on next Friday, my 30 years as a physician, in which I sat across from a patient and next to a family caregiver Almost all my interactions had that dyad. And so now the group of us that is working on this program and the company Navigating Aging Needs, we all have that dual lens. We're always looking at that combination of an individual with Alzheimer's and a family caregiver. And if there isn't a family caregiver, who can be that support for an individual with Alzheimer's disease? Let's not forget those individuals too. So, the Department of Elder Affairs looks around. We are fortunate to meet with them and they become interested in the model we will show you shortly. Yes, thank you. Excellent, on time. The program becomes called Elder Care. So CARE stands for Caring for Alzheimer's with Resources and Education. You're going to see how we do that in just a little bit. Let's see. If you can advance one slide for me, please. We'll move on and learn a little bit more. So we've got the Department of Elder Affairs, we've got the team behind NAN. What do we need then? We need a local champion. So they looked across the state and quite literally they said, you know, we really think the place to do this, I'm going to go ahead and advance one more, please. The place to do this is Broward County. And that's exactly what they said. And I'll go ahead and give a shout out because it's due. Charlotte Mather Taylor was part of the reason why we were able to do this. Charlotte's background includes a range of experience on the healthcare side and the community service side, a strong civil servant of many years, and that type of leadership is what we needed because this is, I'm going to put politics aside, but I'm going to say this is a successful public-private partnership, and I'm really proud that it's come about in that way. We share a collective goal, and I think it bears reading because we all are dedicated to this. Improve outcomes among Floridians with Alzheimer's disease and reduce burden of care for their family caregivers through individualized personal support. I'm going to ask the audio visual people to cue the video for me now. We're going to go right to that. Little video, give you an intro.
For family caregivers, where you can feel confident you're getting high-quality information that is personalized to address your loved one's needs. Welcome to NAN. I'm Dr. Rosemary Laird. I've been helping patients with Alzheimer's disease for over 25 years. I know how challenging it can be for family caregivers and how little support you have on this journey. So in many ways, NAN is my thank you to all the family caregivers I've known and to all of you. NAN stands for Navigating Aging Needs and offers personalized, high-quality, local support to family caregivers of loved ones with Alzheimer's disease. Part of our role is to ensure you get the support you need to protect your own health and well-being. When you register your NAN subscription, you will meet your personal NAN navigator, who will invite you to schedule a 1-hour phone or video conference to answer important questions about you and your loved one. Based on this assessment, your NAN navigator will put together a NAN care plan to help you manage the medical, emotional, social, and legal or financial needs associated with caregiving for your loved one. Your NAN navigator will help you assemble the right team of experts and assist in coordinating your loved one's care. This can be a long journey, and your personal NAN navigator will be your guide every step of the way. You will also have access to the NAN website, nanforcaregivers.com, where you will find support whenever and wherever you need it. Online resources include blogs, videos, podcasts, and training programs for family caregivers. A marketplace with the NAN team's tried and true favorite products for caring for your aging loved ones, and an activity center with fun and relaxing activities for you to take a break or enjoy with your loved one. The NAN care model has been tested and validated as an effective way to reduce the burden on family caregivers of loved ones with Alzheimer's disease. Aging can be complicated. Caregiving shouldn't be. Register now at nanforcaregivers.com and get started today.
Thank you. Well, that's more terrifying in big screens than it is on a little website, but thank you. I hope you got a sense of what we're working to do at NAN with the Department of Elder Affairs and your local area agency on aging. We've been really honored and privileged to work with 235 Broward County citizens, patients with Alzheimer's disease and their loved ones, and it's just been an extraordinary opportunity and time for all of us on the project thus far. I wanted to share with you that we have some preliminary information after just 3 months of this intended 1-year program offering these services to the family caregivers. And what you can see on the screen, we kind of work in red, yellow, green. So as we work to help a family member, a family caregiver, understand the types of resources and education and support they may need, we first ask them what are their biggest challenges. And often it falls into one of those categories I mentioned and you heard talked about. But we also overlay on that an assessment that we bring to the equation that really focuses in on the most common areas that can cause complications across the continuum of Alzheimer's disease. Michael referred to the different stages, and so our assessment is tailored to help individuals who are at all different stages of the illness. And when we get that risk assessment, we then are able to help identify tailored resources that can specifically help an individual hopefully reduce their risk with some interventions. Either maybe they need to read some material and learn how to approach their loved one. Maybe they need to learn Dr. Pandia's what really matters, the 4 M's, and have their medication reviewed. Because they've been falling, for example. Following that, our hope is that there are improved outcomes, reduced risk, and ultimately a reduction in the caregiver's burden and sense of stress from their role as a caregiver. All of that information is aggregated into our color-coded red, yellow, green, where red stands for things that really need our attention. Something needs to be done, or there may be more complications and stress for that patient and caregiver. Green is you're looking good, we can kind of sit back, we've got everything taken care of in that particular area. Let's go work on one of these other higher risk areas. So on the left, you have the baseline score of everybody in Broward County who took our assessment survey. And of all the questions asked, 45% of them fell into the red high risk category. And 39% of them, I know those are hard numbers to see, fell in the green. So we had some work to do at NAN. But I'm proud of our team. I'm very proud of the family caregivers who joined the mostly web calls or telephone calls. We do NAN in any version that'll help a family caregiver communicate with us. So phone and web consults are done. And after 3 months, the red areas have reduced to 42% and our green areas are up. That's exactly the trend we're hoping for. We want risk to be lowered, we want outcomes to be improved, and we ultimately want caregivers to feel more confident, lower stress, feel like they know where they're going. Part of the Navigating Aging Needs title, the name, the spirit behind the name is that I really felt during my career that one major challenge for people is knowing where to turn, knowing that when they turn there was high quality, trusted information that they were receiving. That sort of uncertainty, I think, is what raises the risk, raises the stress levels for most of us quite a bit. So this is what we're trying to do for everyone with this program. I'll go ahead and have you advance to the next slide. And we are proud to say that we have some opportunity to add individuals to the waiting list. The department or the Area Agency on Aging Broward County is going to be managing that waiting list. If you're interested in any information, 2 of my associates are at the Area Agency on Aging table out in the lobby, and they'll be happy to answer questions. We have 2 sign-up sheets. One is if you're interested in being put put on the wait list and learning more about the program from your area agency on aging. And the second is if you'd like to receive our newsletter, which is a weekly blog that I help write and keeps you informed about different resources that appear on the website and may be of use to you. And speaking of the website, nanforcaregivers.com is our website, and I invite you all to go there and look at resources because we certainly hope that the beginning of this program here in Broward County is not the end of this program for the state of Florida and beyond. We really feel like we want to hear from caregivers as well. So if anyone's in the program, I don't know if anyone's here who's used the program. Oh, wonderful. Oh, so our clap was from an actual, thank you, a NAN caregiver. Oh, I'm so excited. Oh, well, we are going to have a question and answer in just a second, so I'm going to strong arm the moderator to make sure that you get the microphone. Oh, we're not doing audience Q&A. All right. Well, well, I guess I'll have to sort of end my time, but thank you, and I'm very happy to have a NAN caregiver in the audience. So thank you very much for your time.
I do want to thank all of our presenters. I think that I knew this was we were going to have different perspectives. It's been great. I thank all of you. We did actually have some questions that I'd like to put out to the panel, if it's all right. And however we can interject the experience of the NAN caregiver, that will be great. I have to say one thing, though, and I guess I'm really dating myself, and as I listen to the three of you, when I started on a neurology service a long time ago, yes, they admitted everybody with presenile dementias, and the people sort of made sense to me, and I would go home and talk to the dog, and thank goodness Mercedes came down here, never told anyone how crazy I was. But in those days, and the reason I say it, in those days, you were either fine or you had a problem. It was black or white. There was no in between. We weren't talking about stages or our understanding of the potential positive things we can do, the negative, before we ever got to NAN. And the one more thing, there was a tendency for families to want to correct the person. And the more the person was corrected, the more agitated they became, needless to say. So I learned at a very young age that we had to have some different approaches. Somewhere along the line, we began to look at the fact that there could be islands of deficits. And I do home health. If it's somebody who lives alone and isn't taking their medicine, yes, we've got a problem, or is in the refrigerator all night. We've got some things we haven't fixed yet, but for the most part, we do have an understanding of the fact that the variation in symptoms from day to day, the variation in symptoms over periods of time, and today is a good start at being able to really find ways of dealing with them and asking about it. I'd like to just perhaps take one question from each of the panel members. Dr. Pendia, you asked about how and with whom what matters should be discussed. Can you share that with us?
Yes, I think, thanks, Diane. It should be discussed as early as possible with family members or family caregivers, because those are the people who are closest to the patient who first detect any changes. And then I think it should be discussed with the primary care physician. And the reason that's important is because that person will hopefully help towards making a diagnosis, direct towards further care needs, and so the primary caregiver needs to also know what matters. And in fact, that's Medicare allows a discussion for advanced care planning with everybody over 65 years of age. And this can be, as simple as, what do I want in advanced illness? Or who will make decisions for me? I think that's the most important. Who will speak for me if I'm not able to speak for myself?
And you may have a lot of resistance, not just on the person who is the center of this, but the family members, because of denial. And that's, there's so many obstacles that we find, which is why the systems that are being developed are so important. Michael, what do you see as both the most commonly asked questions, and I'll make it a two-part question, and the greatest misconceptions that you get on your hotline?
Well, the first part, the greatest misconception is that every person with the disease is the same and they have the same actions and things, and they're not. The disease can change at any time. As I talk about redirection techniques and things like that, what works today on a person with the disease may not work tomorrow. So you are, as Keith stated earlier, you have to constantly learn. And, the other thing would be resources for caregivers. That would be the most things that people are looking for, because most times people don't know who to ask. And as a caregiver, I say all the time, if you can get help, ask for it. If people offer you help, family members, neighbors, whomever, get that help and take it.
Thank you. Rosemary, what are we going to do going forward with all the obstacles that we see?
Well, thank you, Diane. I think one thing I want to sort of chime in on Michael's point about using the 800 number from the Alzheimer's Association. I think that's a really good strategy. I think that it gets you, like Nan, it gets you an individualized time to give your situation, the context, and get someone's answer to that. I also think the resource question is really important. And now that I've been more involved with creating a website, I think the understanding of how people get information off the web is a lot more familiar to me. And so one thing I'm going to do is make everyone raise their right hand and repeat after me.
Let's do it.
Put your hand back up, sir. As soon as I said repeat after me, he's like, I'm out. I will never
I will never
put a medical question
put a medical question
to Google.
to Google. Yeah. Yes.
Yeah, no. So here, you want to use, here's my strategy. Use a trusted local resource. Go to your area agency website first. Find out if they've got what you need, especially from a resource standpoint. From there, someone you can trust there will have someone you can trust. From there, for example, Nan's there, other websites that they have sort of vetted and know that you can trust are there. Go there. Some of the major players from a medical standpoint are fair game, the Mayo Clinics, the Cleveland Clinics, that sort of thing. I'm probably insulting someone at this point, but I'm going to keep going. So go to your local resource first, let them send you to trusted resources. Major advisory groups such as the Alzheimer's Association, that's another trusted site that I think you can go to. But I think you should really be careful about going too far general first. Use your local resources first. Even though you're talking about the World Wide Web, it's very important, I think, to look locally first. We're blessed with an array and depth of talent in this state, and I really think you'd be better off looking there first.
Thank you very much. I want to thank all of the panel members, but I also want to thank all of you as caregivers. I know that we've got family caregivers. I know we've got some professionals. You are a major part of how we can move forward. And the information is, there's nothing bad if you find a trusted person and talk to them, and then hopefully we will continue to move forward. We have a tremendous dementia care and cure initiative, task force in Broward. But most of all, thanks to all of you. And we hope we'll be able to build on this next year. Thank you.